Hi, my name is Mike Pishfine. I'm a GI medical oncologist at Johns Hopkins University, and it's my pleasure to be a moderator here for a GI oncology tumor board. And I'd like to go around and introduce the panel. I'll start with Dr. Zev Weinberg from UCLA.
Hi, my name is Dr. Zev Weinberg. I am a GI medical oncologist at UCLA, Los Angeles, California. Nice to be here.
And then from Emory, Dr. Pritesh Patel.
Hello, Pritesh Patel, Associate Professor of Radiation Oncology, GI Radiation Oncology at Emory.
From Memorial Sloan Kettering, Dr. Martin Weiser.
Hi, I'm Dr. Marty Weiser. I'm a surgical oncologist and colorectal surgeon at Memorial Sloan Kettering Cancer Center.
And finally, from Washington University in St. Louis, Dr. Carrie Siegel.
Hello, my name is Carrie Siegel. I'm an abdominal radiologist at the Mallinckrodt Institute of Radiology at Washington University in St. Louis.
Well, thank you all for joining us. It's going to be some very interesting discussion about some exceptional cases, and I think we should go ahead and dive right into it. So this first case, we have an 80-year-old patient with stage 4A colorectal cancer with metastases to the liver, identified as BRAF V600E mutated from the outset, and the patient had a colon resection for palliative reasons. So the questions are really, when do we consider a patient with colon cancer for metastasectomy? And does the underlying molecular biology modify that decision-making process? So this patient, as I mentioned, presented with intestinal obstruction, nausea and vomiting, abdominal pain, and abdominal distension. The patient was relatively robust until this all happened, and so the ECOG performance status was 2 at the time that she was being diagnosed. There's no real significant medical history and no tobacco, alcohol, or drug use. There was no GI cancer history, but there was a family history of cancer of unknown type from an older relative. The CT scans showed several liver lesions up to 4 centimeters in both lobes of the liver, a dilated proximal right colon, bowel perforation, which is the source of the pain. MRI of the abdomen then also showed multiple abdominal lesions, and a colon and liver biopsy showed adenocarcinoma. A colon resection was completed really due to the obstruction, and the colonic specimen, the pathologic specimen, showed grade 2 adenocarcinoma, positive for lymphovascular invasion, MMR proficient, but BRAF V600E mutation positive, so T4N2A M1A cancer. Before we move on to the imaging, Dr. Weiser, I always struggle with this question in a patient who presents for obstruction or for really bad bleeding from a colorectal cancer. You know, some underlying reason that we're trying to deal with the primary relatively urgently. When would you consider doing a quote unquote full cancer surgery versus just a simple resection versus just a diverting ostomy for a patient?
Yeah. So it's an excellent point. In the setting of a perforation, you definitely want to remove the site of infection or perforation. So that would mean taking out the primary tumor. I think if you think at all you're going to get to a possible curative intent surgery, then you should do a cancer operation. It usually does not add that much more to the procedure, and sometimes it's almost easier because you're dissecting in an anatomic plane. So we almost always use a standard cancer operation. A diversion is generally not a great option. We do it when we have to, sometimes in rectal cancer, where we want to use neoadjuvant treatment before attempting resection, we'll divert. But for colon cancer, unless it was sort of a matter of life and death, we would try to resect rather than just divert.
Very good. All right, so Dr. Siegel, this is what the MRI looked like.
You can see here that there are multiple lesions in the liver, all worrisome for metastatic disease, probably involving multiple segments, 7, 4A, and probably 2. And this is just on one slice.
Yeah. Well, to that point, actually, good segue. Dr. Siegel and Dr. Weiser, this is where tumor boards become really critical. But how do you all go about making decisions about who really has resectable metastatic liver disease?
Well, in my opinion, the hepatobiliary imaging MR is much more sensitive than the CT for identifying the amount of liver lesions. So if the amount and the different segments that they're in, if that's going to be important to decisions on management, I usually prefer that to a CT.
Yeah, I would agree. A lot depends on the remaining liver remnant after complete metastasectomy. Is it sufficient? We often can do staged operations to allow regeneration of liver, to allow a second stage operation. And then, of course, there's borderline that we would treat with chemotherapy first to try to get to resectability. So really, resectability is in the eye of the beholder.
Gotcha. Dr. Patel, can you talk about the potential role for radiation for treatment of oligometastatic colorectal cancer?
Sure. Important topic. I think for those patients who a multidisciplinary team is intending on a curative intensive course, in that case, the metastatic lesions are sort of one part of the equation, and then the primary the other. So we sometimes encountered this with rectal cancer, and in that case, the standard recommendations for radiation, I think, continue to be followed. So if radiation would be needed for the primary tumor in the pelvis, we'll often use it, and there may be some consideration maybe for a short course of radiation as opposed to a long course in that setting. I think in our institution, for any lesion that's potentially resectable or resectable, certainly, we would always, I think, choose a surgical resection as opposed to any radiation. But sometimes a combination approach is needed, where SBRT could be used for lesions that might require a large anatomic resection or something like this, in combination with other surgical or ablative therapies for metastatic disease.
Dr. Weiser, Dr. Patel kind of brings up something that I personally have struggled with a lot, and I'd love to get your perspective, which is really the timing and sequencing for a patient who has a primary lesion in place in the colon or the rectum, and then a clearly operable, let's just say, one liver lesion. Who goes first, and how far apart are the two operations?
Yeah, I mean, this is an excellent question, and as well as what's the role of chemotherapy. I would say in the past, we would almost always treat with chemotherapy first. I think now we're often move to resection, if that can be the first step, if we can get all the disease out in a reasonable operation. At our institution, we are very much in favor of combined resections, and we do them very frequently to clear all the disease in one setting, to avoid two anesthetics and two perioperative risks. As far as on the day of operation, the liver surgeons will often go first for a low CVP operation or resection, meaning that you keep the intravascular volume very low to reduce bleeding at the time of liver resection. And then once the liver is resected, you hydrate, and we can move on to the colon resection. But that's not uniformly performed at all institutions.
All right. Dr. Weinberg, molecular testing should be standard of care, at least for some very, very basic molecular tests that we're going to be talking about in several of these colon cancer cases, RAS, BRAF, MMR testing. And so a lot of the pathology labs really across the world now are doing that level of testing right away on the first biopsy sample. And many gastroenterology offices are doing it in-house just with the biopsy specimen of the diagnostic colon biopsy. So we are fortunate to be getting some of these molecular testing results back very quickly. And so I'm wondering, for you, or actually for the whole team, would any of the local management decisions be modified by the molecular profile?
So I certainly think that we are encouraging people to get this as soon as possible now, in the sense that it's valuable information for discussions about even adjuvant therapy sometimes, but obviously the role of these therapies and based on molecular decisions is at this time exclusively in metastatic disease. We until the patient is ready for systemic therapy, we would defer to local therapy. We wouldn't necessarily add off of a clinical trial, of course, any targeted therapies or additional therapies before the local therapy plan is complete. I will say that some of this information is very important prognostically. And so for this patient, for example, a microsatellite stable BRAF mutated colon cancer, we know has among the worst prognosis of colorectal cancer with a much shorter survival expectation. And so having that data in this current situation, I think does add color to the discussion at the multidisciplinary tumor boards because it informs a shorter prognosis.
Got you. Okay, so I think the panel for this case, first of all, really we talked a lot about the role of metastasectomy, and I think that the upshot of it is the very team-based approach and can vary from patient to patient, but the ability to do either staged or concurrent resections that include a metastasectomy and a removal of the primary are definitely decisions that are made on a regular basis at these institutions. Some of the decisions on who is a candidate for liver metastasectomy has to do with the radiologic decisions, and getting an MRI is critical, and understanding how much of the liver that's going to be left behind is also critical. And then as far as the underlying molecular biology, I think it wouldn't necessarily trump local therapy, but we do know that certain molecular subtypes have a worse prognosis than others, and certainly the underlying molecular biology will be critical for later stages of therapy if the patient needs it.